So we have, next we have Dr. 𝐺𝐫𝐢𝐫 my good friend and colleague from Artemis. And between Dr. 𝐺𝐫𝐫 and Mr. 𝐲𝐫𝐫 Ganguly, who will be coming in the next hall as the chief guest for the inauguration session, we'll have another sponsored session, which is on the current status of hypothermic oxygenated machine perfusion in organ transplant by a liver transplant surgeon from Zurich, Philipp Dukowski. So this will be after Dr. Bora's presentation. And then we wind up the scientific session here. And those people who would like to join the inauguration will be after that. Dr. 𝐺𝐫𝐢𝐫 Bora.
So thanks, Dr. Ramdeep and rest of the organizing team of ISOT 2023. So last talk of the day, but not least, and because salvaging every single graft is important, so my topic is to salvage a graft by intervention radiology means of portal vein stenting. So everybody knows that portal vein thrombosis is a disastrous complication after transplant, and once it happens, it can kill the patient and more early than a hepatic artery thrombosis can. And everybody knows that the incidence of portal vein thrombosis is higher in pediatric cases as compared to adult transplants. So broadly speaking, the thrombosis can be divided into two categories. First being intraoperative, or those occurring soon after the transplant. And second is portal vein stenosis, or formation of a portal vein cavernoma, which we come to diagnose months after the transplant. So it's the first category where I'm going to present my work, as well as some literature evidence. So incidence of portal vein thrombosis, obviously we have some high risk group, and I just said that smaller babies, those suffering from biliary atresia, and weighing around 6 kgs. So possibly those are the group of patients have higher incidence of or higher chances of portal vein thrombosis as compared to an adult transplant. So a typical patient you see in your OPD is a 6 months old baby suffering from biliary atresia, and once you do the CT scan, what you see is that although SMV is quite decent in size, but once it becomes portal vein and traverses towards the liver, you see that it becomes quite small in size. And possibly these are the group of patients where one can anticipate the higher incidence of portal vein thrombosis as compared to other cases who have a relatively larger caliber portal vein. So the conventional wisdom is prevention is better than cure, and maybe some of the steps can be taken to minimize, if not completely, eliminate the chances of development of portal vein thrombosis following reperfusion of graft. And I'm going to talk about them in my next presentation slides. So dealing with a hypoplastic portal vein, and which is common in babies suffering from biliary atresia. And we can appreciate in this picture that this portal vein here is quite thick walled. That is because of fibrosis of suprapancreatic portion of portal vein, which is quite common in babies suffering from biliary atresia. Similarly, so we need some sort of a replacement or augmentation in order to increase the flow of blood across this hypoplastic portion of the portal vein. So we have either a replacement technique or augmentation technique. So our preference is always to replace the atretic portal vein or a small caliber portal vein. And for this, we dissect the portal vein to the junction of SMV and splenic vein. And once you do it, you need a graft to replace and somehow increase the size of this hypoplastic portal vein. So unfortunately, unlike the Western world or Southern India, we do not have the luxury of cadaveric veins. So unfortunately or sadly, we are forced to ask our donors to bear one more incision over their neck, and we retrieve the internal jugular vein from these donors. And once you replace this atretic portion of the portal vein, one can see that portal flow is excellent, and one can appreciate the excellent flow on the CT scan, that how it changes, how the change in the caliber can augment the flow, wonderfully in most of the cases, and one can anticipate the minimal chances of venous complication following transplantation, even for the babies who have very small portal vein. Now, creating a wide outflow. So everybody knows, outflow is a key to prevent any outflow related issues in the short and long term. But it is also important that to create a good outflow to prevent any back pressure changes and the secondary portal vein thrombosis caused by increased pressure within the liver. So augmentation, triangulation, and creating a wider anastomosis are well-known technique. But sometime, we did this case 2 months back, and here what we can see is that it was a graph for a small baby, and segment 3 hepatic vein was joining middle hepatic vein. So the division of segment 3 hepatic vein over here would have resulted in two different venous opening falling quite apart. So what differently we did here, that we divided the middle hepatic vein over here rather than, So we divided the middle hepatic vein over here rather than dividing the segment 3 hepatic vein. And what we found that by dividing the middle hepatic vein over here, we could achieve a single opening of segment 2 and segment 3 vein. And then this stump of middle hepatic vein was closed on bench. And obviously, there was excellent outflow in this baby, and we did not inquire any vascular issue in the post-transplant period. Now talking about last step, which can be taken to minimize the chances of portal venous thrombosis, is to have a size match between patient body and the graft. So the large for size graft, it is also a risk factor for PVT, and the proposed mechanism has been the portal flow stasis and a tight abdominal wall closure, which will jeopardize both inflow as well as the outflow, as well as the inflow across the graft. So the reduction of graft size can be done by anatomical or non-anatomical means. So we in Artemis Hospital are proponent of doing anatomical hyper-reduction of the graft. We can see here in this picture. So depending upon the graft volume, depending upon the anterior posterior diameter of the baby's abdomen, we can either choose between segment 2 or segment 3 graft. However, Dr. Gupta and their team has recently published about non-anatomical reduction of medial segment of the graft with very good results. But we have been advocating anatomical hyper-reduction of the graft in order to minimize the biliary complication in these small babies. Now coming to something which is inevitable and is my main topic, that is salvaging the graft. So in spite of best of our effort, you do some sort of an augmentation, you replace the suprapancreatic portion of the portal vein. In our clinical practice, we sometimes encounter a situation where portal flow is so slow that we suffer repeated episodes of intraoperative portal vein thrombosis. We revise anastomosis multiple times, it doesn't work. Correction of angulation doesn't work. So those are the situations where intraportal vein stenting works wonderful to salvage the graft as well as the patient. So there are a number of approaches which have been described in the literature, but for the smaller babies, we found that IMV approach is very difficult. So we tried 3 different approaches, one through SMV, which has been showed in the first picture. And this technique we used in 3 cases, first 3 cases. The next 2 approaches, one by a segment 4 portal vein, and the last one by cut end of the umbilical vein, which has been published by Dr. Neerav and their team recently in Journal of Pediatric Transplantation. So the technique is to pass a guide wire across the anastomosis and then deploy a 10 millimeter 14 mm long stent across the anastomosis. So it's extremely important to cover the site of anastomosis because it takes care of some small angle or rotation. And once you do this, one can see that, one can appreciate there is a stent lying across the anastomosis, and whatever less be the amount, once you place the portal vein stent across the anastomosis, the flow is excellent in most of the cases. And unlike, which has been published by Dr. Neerav and their team, we do not leave any catheter across the anastomosis, but we just go on or continue with the anticoagulation in the post-op period. Now talking about our experience, so these 23 cases we did in last 2.5 years. All of these babies, which I'm showing over here, are either equal to or less than 1 year of age. And most of these patients are weighing less than 10 kg. So the initial 3 cases, we were forced to do portal vein stenting. We went by SMV access. But the problem we faced was that all 3 babies, we had intractable 𝐾𝐻 ascites in the post-op period. So we changed our approach in last 2 cases. In one of the babies, we used segment 4 portal vein access. And in the last baby, we used umbilical vein access. So in both these patients, where we access the anastomosis via segment 3 portal vein or via umbilical vein, we did not have the problem of 𝐾𝐻 ascites. So I mean, if you require, I mean, such a problem, I would say, I would urge that SMV approach is little difficult in these babies because you have intractable 𝐫𝐼𝐴 in the post-op period. But a segment P4 approach and the umbilical vein approach seems to be satisfactory in case you need intraoperative portal vein stenting. So now lastly, showing picture of a baby which we transplanted 2.5 years back. So this was the baby, I mean, we used IMV in fact, but it did not work. Portal flow was so less. So this baby required portal vein stenting during the surgery, and he's now almost 2.5 years following the surgical procedure. He came for a follow-up, we did a CT scan, and the flow was excellent across the graft. So to summarize, I mean, avoiding a stent should be the aim, but unfortunately, I mean, seldomly, once in a while you encounter a situation where in order to salvage the graft and patient, you are forced to use portal vein stenting, and it's an excellent salvage technique, at least in short term, to I mean, wave you, I mean, somehow your savior to come out of this I mean, deadly complication following liver transplant. Thank you.
Thank you, sir, for an excellent presentation. I think all those surgeons who are pediatric surgeons, pediatric liver transplant surgeons, have come across this problem of low portal flow at some point of time or the other. I feel that this umbilical approach is probably a little easier than the other approaches. What do you think?
Yeah, so I mean, previously we had no idea about this umbilical vein approach. So because we require stenting sometime in adult patients, so we are accessing them through IMV route or sometime through peripheral branch of the SMV. But in pediatric cases, actually IMV is too small and the peripheral branches of SMV unfortunately are too small to cannulate. So we went directly onto the SMV, infracolic portion of the SMV, and tried to access portal vein through there. But then, I mean, we burned our fingers. We had this 𝐾𝐁 problem, so we thought of finding a different solution. So one paper we encountered from Japan was using this segment 4 portal vein. And then there was one more publication from Apollo Hospital, New Delhi, that I mean, they were accessing through umbilical vein. But they are opening umbilical vein during donor surgery. We don't do that. We didn't do that. So what we did, I mean, we retrieved the graft, and then we somehow manipulated the instrument from both the sides, basically through cut end of the portal vein and from the cut end of the umbilical vein. So I believe, I mean, it is easier on the bench to open the portal vein and the cut end of the umbilical vein rather than, I mean, doing it in situ while the graft has not been taken out from the donor's body.
Okay. Thank you. Questions?
Good evening, sir. Well summarized, sir. As I saw your slides, the main primary aim of deploying the stent was around the anastomotic side.
Yeah.
So what do you prefer? Do you have a specific length of a stent do you prefer, or is it just covering the anastomosis? Which is my first
So basically,
question.
the length of the stent is around 4 centimeter, basically.
4 centimeter.
Yeah,
And what
and
do
the
you
size, I mean, size can be variable. Like Dr. Nirav, I mean, they said that they are using 8 mm graft, but we are using 10 mm. I mean, bigger the size, I mean, less is the problem, what I believe.
And what do you prefer, a covered or uncovered stent?
No, it's always an uncovered stent. I mean, it cannot be
Uncovered.
covered stent. Otherwise, the flow from splenic vein will not come. So you will have left-sided portal hypertension. So it has to be an uncovered stent. I mean,
Thank you, sir.
Any other questions? Otherwise, we will close the session now.